All right. Well, hello, everybody. Good afternoon. Welcome. My name is Andre Zinchuk. I am a pulmonary critical care and sleep doc here at Yale. And along with our colleagues at Beth Israel, Brigham's, NGH, Tufts, and BMC, um, we run the joint sleep medicine seminars and between these centers, and it's been quite a wonderful journey for us. And so I'm just going to give a quick introduction about the seminars and remind people and folks who are just joining us perhaps for the first time what these seminars are about. And then I will hand the mic over to Dr. Craig Kanapari from Yale, who's the director of the sleep program and the sleep lab and fellowship at Yale University for pediatrics, and who will introduce our esteemed speaker today. And so just as a reminder, we are currently hosting these talks among 6 different institutions, and we started this conference back in 2019 to help cross-populate some of the ideas and expertise across different institutions, and it turned out to then include folks even outside of our group. And so we've had over 35 talks in the last three and a half years, and anything spanning from drugs for sleep apnea, wearables in medicine, insomnia, cardiovascular disease, sleep memory and dementia, sleep in older adults, central sleep apnea, COVID and sleep mitigation of sequelae, and then a host of other topics that are pretty exciting and interesting, varying from different domains of sleep medicine. And so really pleased about this excellent lineup of speakers, and today's speaker is wonderful as well. And so just a little summary of what we've done so far. 2,300 is the number of attendees for these seminars since our inception in early 2019. And that sort of translates to about 84 people per session, which I think is a pretty good number and distributes out the knowledge and expertise across different institutions quite well. And so without further ado, I will hand the mic over to Dr. Craig Kanapari from Yale, who will introduce our speaker today.
Thank you, Andre. It's my great pleasure to introduce Dr. Christopher Hartnick, and it is a show of my affection and respect for Chris that I actually put on a collared shirt while on sabbatical here. Those of you in Boston may be somewhat familiar with Dr. Hartnick's work, but for those of you who are not, let me just fill you in. Dr. Hartnick grew up in New York City and was educated at Princeton before going to Einstein for medical school, where he also completed his otolaryngology residency before going to Cincinnati for his pediatric fellowship, which was really, in Cincinnati, was really ground zero for the way that pediatric airway disorders are managed here in the United States. He has several R01 grants and has published many, many articles, textbooks, chapters on pediatric airway management. He's also traveled on medical mission trips, including to some dangerous places like El Salvador. He's been in Boston at Mass Eye and Ear since 2001. Coincidentally, the year I started my residency year just next door, and is currently a full professor at Harvard Medical School and holds the Benjamin Harry Pelkin Chair in Otolaryngology and Head and Neck Surgery at Mass Eye and Ear. When I was asked to give this introduction, I realized that I've known Chris for over 20 years. On a personal note, it's not an exaggeration to say that Chris is one of the reasons that I ended up in sleep medicine, as he founded a pediatric sleep laboratory at Mass Eye and Ear, which at one point I ended up running for some time when I was still in Boston, although secretly he remained the power behind the throne. If you are working with Chris on a problem, whether it's a clinical challenge, a systems problem, or a research idea, he will work tirelessly with you to find a solution and will will it into existence. I'm fortunate to consider him a mentor and friend. So thank you, Dr. Hartnick, for giving us a talk today.
Well, Craig, I feel like I paid you for that. That was so nice. And thank you so much. And God, the only thing that's more frightening than that is the fact that it's been 20 years and time goes so fast. What a pleasure. And thank you. And thank you both. And for those that you, that I don't know, this is my email, and feel free to email me afterwards with questions. I have a disclaimer slide next that I was very happily sent, which I have no disclaimers, but my biggest disclaimer is I am not an adult practitioner. I am not a sleep trained doctor. I am a pediatric ear, nose, and throat doctor who with a lot of interest in kids with sleep disorders. would spend the first 10 years frustratingly trying to treat some of them, and that sort of is the beginning of the story. So any questions are welcome at any and all times or at the end, and just take that as this disclaimer. So here's the official disclaimer. And what I would just start with is I did come from Cincinnati Children's in the land of Sally Schott and then Stacy Ishman later on, in different worlds, and now Dave Smith and Christy Kuby. And when I was at Cincinnati Children's, like when I then came to Mass Eye and Ear and Mass General, both places had treated enormous numbers of kids with Down syndrome. A, because it's the most common chromosomal disorder, and B, because both places have a Down syndrome program or a Down syndrome clinic for really holistic care for these kids. These kids are enormously cute because they smile all the time and are wonderfully, and I love them and their parents in general. They're enormously frustrating to sleep practitioners and pediatric ENT surgeons, because we like for what we do to be successful. And in pediatric sleep apnea of Down syndrome, we start off by removing their tonsils and adenoids. Anybody who comes into our office for pediatric ENT, we will consider removing your tonsils and adenoids. Often it is somewhat successful. In this population, as you know, it's very often not successful. And depending upon the study that you look at, 30 to 60% of kids with Down syndrome may have sleep apnea, and 30 to 50% of them may still have sleep apnea after you've performed your adenotonsillectomy. You then can go down your algorithm of bony versus soft tissue disorders, and we can think about issues such as, is their palate redundant, or do they have lingual tonsils? Are their septums straight? Are their turbinates large? Do they have laryngomalacia? Do they have subglottic stenosis? Is there something bony that we should think of? And prior to the New England Journal article that I know all of you know, especially the adult practitioners, I spent about 10 or 15 years performing posterior midline glossectomies on these children after we had walked down this road of thinking about the various soft tissue procedures we could do. And Dr. Schott was the one who taught it to me. It then was popularized by Evan Probst and group at Toronto Sick Kids. It's a wonderful procedure when it works. It's a terrible procedure when it doesn't work. It's quite painful for the kids, and which would be okay if were it to be predictable. The reason I was excited about this article was, in my hands, posterior midline glossectomies were not predictable. I couldn't predict how successful it would be in reducing sleep apnea to put kids through their morbidity of either tracheing them temporarily or leaving them intubated for a period of time. I still do this procedure for kids who don't qualify for hypoglossal nerve implantation, as maybe we'll touch upon before or after. But this article, in 2014, really piqued my interest. And Ryan Seuss, who's at Pittsburgh, who's a good friend, when I went out to Pittsburgh, and then he flew to Boston, and we thought to ourselves, well, if the phenotype of kids with Down syndrome is that so many of them have a large tongue posteriorly, not like the kids with Beckwith-Wiedemann who have anterior tongue issues primarily, but have posterior tongue issues, would this device be safe and effective for this population? And I am speaking to a professional audience of sleep practitioners, so I'm sure all of you know about these Inspire hypoglossal nerve implants. They're different hypoglossal nerve implants. This one has a sensory lead that goes somewhere under, usually on the right side. This isn't the older picture. Now it's up around the second or third rib. But when the patient senses that the child or the adult is going to take a breath at night, and it sends that information to a processor, which then sends a signal to the branch of the hypoglossal nerve that moves the tongue forward. For the non-surgeons in the room and those who haven't used this device, your hypoglossal nerve is like your facial nerve, that it has branches of your hands. Certain branches move the tongue side to side, certain branches move it backwards, certain branch moves it forwards. And so this cuff goes around the branch that moves it forward. And to really focus on the work that we've done since we asked that initial question, when you start asking a question, can a device help a certain population, especially when that population is a pediatric population, especially when that population is a pediatric special needs population, you really want to entertain that notion with regards to your IRB, your ethical review board, and in this situation with the FDA, since this was a non-approved device or a device that was not approved for that population. So these all what the studies that we'll be describing are all FDA IDE studies. The first of which was not NIH co-sponsored, and the second of which is NIH co-sponsored. But the first study was really to answer the question: is it safe? And this for this population, and the second was to say, was it going to be effective? And the effective meaning can mean a lot of things to a lot of different reasons. We started off by saying simple reduction in the AHI, and then as we'll talk about, the story changes. So the two studies that we've done were first from 2015 to 2019, and now from 2020 to 2025, and time flies. The first being the study that I talked about, looking at this initial safety and efficacy results, and the second really looking upon the effects of implantation and the treatment of sleep apnea on neurocognition and expressive language in this population. Both of these have inclusion and exclusion criteria that I really started by mirroring on the STAR trial. And for any of you who have the joys of setting up clinical trials, either with the FDA or the NIH, thinking about your inclusion exclusion criteria is a little bit of a lesson in frustration, because 3 years later you wish you had changed it somewhat. I started off with kids 10 to 21 years of age who have Down syndrome, defining the AHI as greater than 10 and less than 50, thinking that greater than 50 it might have comorbidities with regards to a BMI being greater than 95th percentile, and knowing I had to have some number that I had to hold it to. The BMI had to be under the 95th percentile. They had to have persistent sleep apnea despite a TNA. They had to either be intolerant of CPAP or on a trach. Intolerant being a soft word that we could describe either by a parent telling me that the children were intolerant, or some kids with Down syndrome, for those who treat them, have such sensory integration that they won't let CPAP go near them unless they see Dr. Canapari and he works his magic. Or there are programs where Greg Young at Spalding and Franciscans does work with a desensitization, which is interesting, and having an appropriate sleep endoscopy showing that these kids, their primary obstructor was their tongue base. And then there are three reviewers around the country that independently review these, and then to say, I will say that again, with the context of this, now that we've flashed forward to where the FDA has now approved this device for 13 and above, we can now implant a BMI greater than 95th percentile, and we're looking at that cohort. And my thought will be it's primarily dice driven to be able to say who will benefit from this or not, but that's why we have research to ask questions. Some things that may be different as we go along between pre and post implantations. Is it, again, with kids, this question of whether or not we can implant kids who have a greater than 95th percentile BMI. Remember, for adults over 18, you don't use these percentiles. We use these percentiles, and therefore it's more strict numeric cutoffs. But the short answer is, for both pre and post sleep endoscopies, for those who do it, sleep endoscopies work when you work well with your anesthetist. They don't work when you don't work with your anesthetist. I will just say that you have to have a sleepy child, an obstructed child, in order to have an appropriate sleep endoscopy. You also really have to see what happens when the jaw thrusts and the chin lifts to see if the airway works or doesn't work. The only direct contraindication to a sleep endoscopy is if you have circumferential palatal collapse, because that's not innervated by the 12th cranial nerve. It does not matter whether or not you use Precedex or propofol or whatever agent you use. I'm pretty much agnostic to agent. It's so site dependent as we've been doing this, but it's the keys in mind, what you're trying to achieve, that's important to speak with your anesthetist, that you want an obstructed child in a plane you can do a video recording of. I will say, with regards to specifically with regards to the Down syndrome population, when we first were looking at this, we were excluding a fair number of kids we thought had circumferential palatal collapse, until we had the bright idea of suspending the children and looking to say that kids with Down syndrome have eustachian tube tori, which is much larger than your adult, your normal pediatric population. So when you see a child with circumferential, or what you think has circumferential palatal collapse, it is really important as well to look at the look upwards, as if you would be performing an adenodectomy, to see, is it truly circumferential collapse, or is it a misconception from very, very large eustachian tube tori? Because those kids we have implanted well with good effect, but that's an important difference for us. With regards to intraoperative cuff placement, up here we're seeing an intraoperative visualization of the hypoglossal nerve with the C1 branch. Thank goodness for Frank Netter and his drawings in order to see. As we go from inferior to superior, the inferior branches tend to be the protruders. The superior branches tend to be the retractors, and those making the tongue go side to side. At a certain period of time, you'll have a break point, which we identified by nerve monitoring, and we place the cuff around those branches of the protruder of the nerve that move the tongue forward. This is not part of our study, but just to say that how young can you go? This mimics the cochlear implant world, where when I was I'm old enough to remember this training, when we said we couldn't implant a child, do a cochlear implant on a child 2 years or younger. Now we're implanting kids 1 year and if not younger and over for hearing loss. This is a 4-year-old child I've known for an extremely long period of time, his whole life, in fact, whose parents were just at their wits' end with this child, who we implanted about eight months ago. And this is there just to say that this is the intraoperative pictures, and to say that yes, you can implant for a child much younger than 10 years old with this technology. And as we go forward and talk about neurocognition and expressive language, since so much neurocognition takes place between the ages of 4 and 10, the minute the FDA approved 13 and over, of course, they're ready for me to start badgering them to move younger and younger and younger, because I think this is a critical period for us to think about in terms of kids and needing implantation down the line. Post-operatively, kids with Down syndrome love to pick at their scars. So once I had my first child pick the wound enough such that they picked the stimulator lead out of their incision, which then I had to put back in. Now we keep the bandages on for an enormously long period of time, and just tell the parents that. Post-operatively, I would just say, and I'd be interested in your, for those of you who help implant kids who are adults who in terms of the post-operative optimization of the sleep studies, with the I'm sorry, my window's super right to this rain, so if you can hear me, then I'm going to keep going. What we'll say with these situations with I've had 3 kids I've implanted now, and that were what we called treatment failures. I implanted them, and afterwards I could not optimize them. I couldn't get them to work for normal standard techniques. And still, we started to look at their inhalation, exhalation timings and the sensitivities on their sleep study, on their optimization studies, and on their actual sensing lead. And I would just say that this is something that we really haven't been looking at in pediatric sleep studies post-implantation enough. And
And I think that now that I realize that A, it could be a sensory lead function, and B, that some of these kids, the sensing lead just doesn't gate to their inspiration and expiration, and there is an inversion button on the settings that often we have to trigger this so that we're getting them to the right when it gates to them both breathing in and breathing out enough. So what Inspire would call is advanced titration sensing is really important for the kids who you think you're not getting an adequate result on. And that may be having the adult Inspire reps either there at your sleep lab itself, which is what we do because they're part of our study, or online for this. So just something to think about. So for our first study, just to go to the data itself, that it was a male to female predominance slightly. You can see that there was an age distribution from 10 to 21. All of these kids were under the 95th percentile. Depends how you define success, right? At first are you looking at a statistically significant drop in their AHI, which obviously there was a significant drop from 23 to 11. Are you looking for a 50% more? What number of kids have a 50% decrease in their AHI or not? What number of their kids have their AHI under 10 so they no longer have severe sleep apnea? The success rate changes according to what your outcome measure is. Or is your success rate simply that your average nightly use was 9 hours instead of 3 to 4 hours, which they may use for CPAP? So all of these are potential outcome measures that one may think about. In terms of complications, just to say there were no long-term complications of these from the implantation so far around the country on the kids we've implanted. One child, as I said, picked out their stimulator lead, and we put it back in and put him on antibiotics, and it worked. Another child in Cincinnati, when they were just switching it from a non-MRI compatible to a partially MRI compatible, the way of putting the leads into the processor was such that it wasn't fully pushed in, and they had to do a second operation simply to put the pins in, and then it worked. But there haven't been any long-term complications of this. We have done some publishing on this, both to say that the top paper is the results of our first 42 kids, showing that it was safe and preliminarily effective. This was the data that was predominantly used for the FDA to approve the device on World Down Syndrome Day last year, which was for kids 13 years and older. We've then looked at the subpopulation of kids that have been implanted for more than 5 years or since that period of time, just to say what happens as they grow and develop, and is it still stable? And so far, so good. It's been stable. And we did, while we were going along the way, the parents would report to us that their children were doing well neurocognitively in terms of school, attention, mood, and speech. And the third article speaks to that, which we'll talk about in a second. So this just says again that we looked at all these different factors, and in the and at least in the number 1, 2, and 3, we showed success. In terms of 4 and 5, the Breslin article saying that we should be shooting for an AHI less than 2, because for kids with an AHI greater than 2, they would have neurocognitive deficits down the line. It's hard to get to 0 or hard to get to 100 in medicine. AHI less than 2 is a hard thing to shoot for. We really haven't shot for this yet. In terms of percent of those implants who no longer need positive pressure, there's no really good consensus for that, and who needs positive pressure and who doesn't. So we were a little between center to center. We stuck with the top 3 definitions for those reasons. But in terms of restoring this concept of listening to your patients, these kind of comments were the kind of comments we got, that she's a different, better kid, that she's connecting with other people, she's connecting with the world around her, her speech has improved. 16 caregivers reported this, and we asked, was it real? So in the last 6 kids that we looked at in that first, as a nested cohort of the 42, we did, Len Abudetta has a wonderful, expressive language profile at UC Davis for kids with Fragile X and Down syndrome. And he was kind enough to lend us his scales. And we did neurocognitive testing on those 6 kids. And interesting, for those 6 kids, none of whom had an AHI less than 2, all of whom had a postoperative AHI between 5 and 10, who, according to the Breslin article, would be would be at risk for having neurocognitive deficits, their IQ went up half the standard deviation. This now again that is not significant because it's a trend, as well as their attention and memory did well, and their expressive language improved dramatically as well. So when we got to using this as the pilot data, so the pilot one study begets another study. We used this pilot data to say, well, what we're really looking at, we're interested in is neurocognition and expressive language. Using the neurocognitive measures have been standardized for the Down syndrome population across pediatrics, and Len's work has standardized this for the expressive language population. So this is our current UO1 because it's a multi-centered clinical trial running across 5 institutions. And I think the reason why we're so excited about this is because really, parents don't come because of their child's AHI. They come because their child can't sleep, and therefore they can't function during the day, or they can't sleep and they can't function during the day as parents. So the current study is looking at 57 kids at 5 centers over a 5-year period of time to see if the hypoglossal nerve stimulation and treatment of obstructive sleep apnea will improve neurocognition and expressive language by at least half a standard deviation or more. We are part of the include granting process, so therefore we are very much looking at DIE issues and trying hard we are now IRB approved for kids who are Spanish speaking, who are bilingual children, can be as the parents can be monolingual Spanish alone, as long as the children can be bilingual. There is no Spanish standardized Spanish verb expressive language score that we know of for children, so it has to be bilingual kids. We are looking at kids off the study right now who are greater than the 95th percentile to look at that cohort itself. So we are looking at a diverse cohort and their outcomes. I think I'm going to stop there and really, that's where we are right now. In terms of, we are now 27 kids out of 57 kids in, with another 2 years to a year and a half now to recruit through 5 centers. So if you have children regionally that you have interest, do feel free to email me. These are the different sites where we are implanting. It is interesting that on the good news is that the data was such that the FDA approved kids 13 and over. The bad news means, why would you enter a study now if you could get your child implanted off label? Just realize that the study has nothing to do with whether you'll be implanted or not. The only thing the kids would be getting is pre and post neurocognitive and expressive language testing. Everything else will be the same. So we're hoping that at least at our center, no one has said, I just implant me off study. So far, anybody who could be would be, but it is, in terms ethically, they have to know that is part of their their prerogative to go either way. So that is where we are right now, and I hope this is of interest to adult practitioners. I think there's many more questions for how young can we go, and what the effect will be on neurocognition and expressive language. And maybe I'm going to stop sharing and open it up for questions. Thank you.
Chris, thank you. That was really interesting. I think you alluded to just the challenge sometimes of taking care of these patients. It's always a pleasant surprise when the AHI actually gets them where they need to be. When the adenotonsillectomy does. Do you see other patient populations besides Down syndrome where this might be potentially useful?
Oh yeah, no, we picked this population. I mean, since this, yes, I think for the appropriate child who has a neuromuscular weakness where they needed nighttime positive pressure but couldn't tolerate it, and where a sleep endoscopy showed that it was really tongue-based obstruction because that caused that issue, those kids might be terrific candidates for it. I'm obviously hypothesizing because I don't know, or haven't done that yet. I don't know. I've refused. And the other child, the other population is for the kids who are non-Down syndrome, otherwise kids who have gone through this whole soft tissue procedure and can't tolerate CPAP, just like adults receive hypoglossal nerve implants. Should those kids? So far, I've really begged away from that question, just because kids, when kids become adults, they change so much and their morphology changes so much that I haven't wanted to go that route. But I don't pretend to have the long answer to that.
Yeah, I mean, so many of the kids we see who need CPAP or don't have a syndrome, or they're tend to be quite obese as well. So they still could have they could still have the right kind of collapse, but weight management is such an important part of it.
Yeah.
I think I have a question here from Dr. Yagi. And Clara, maybe jump in if I'm not parsing this correctly. Clara Yagi is asking can you explain further your comments about looking at the timing of the sensory and stimulation in an effort to improve the efficacy of this device among some patients? Clara, I think what you mean is like why this might be helpful younger versus than older. Is that correct?
Can you throw some? I can't read the comment. Hold on, let me see. I'll get to this.
Sorry, I was muted. No, I think you had, Dr. Hartnick made a comment that in some patients where you didn't see a robust result with this or an optimal, you had made a comment that there was some dysynchrony or time. You said looking at the timing of the sensing lead and compared to, if I understood you correctly, in order to troubleshoot and to improve the efficacy of the device. And I didn't fully follow that comment.
Yeah, no, thanks for the question. And interesting. It's something that I'm going to go back to what as we talk. The things that we've seen so far. I don't know. I don't know why this is, but it's as if the inhalation exhalation of kids with Down syndrome, it's arrhythmic rather than rhythmic. So in a lot of the kids, when you look, it's the SET device for Inspire is it's gated to inhalation and exhalation, and for some reason I don't know the answer why the kind of dysrhythmic breathing pattern switch inverts it on Inspire. So when you hit the invert button, right, it resets it, and then it gates it to that child's inhalation and exhalation more. And the honest answer is, until we did that, I don't know why that is. My sense is what it does. It's almost like resetting it and saying to the device, look at that, personalizing it, relook at inhalation exhalation curves to look at that. But that's just an important piece to look at. Does that make sense?
Yeah, no, thank you for that. I was just curious, because we certainly see suboptimal titrations in adult patients, and it sounds like you're inferring that this may be specific to patients with Down syndrome. But I'm wondering if this may be more a generalizable problem.
Yeah, I actually think it's much more of a generalizable problem, and I would just say to you, as we happen to now, I've gone through 3, and what I wound up doing is asking Inspire to bring their most seasoned sleep tech to our lab to look at our failures. And when we looked and I had 5, which I would have said were not what I wanted them to be, and he was able to do things that our techs were not able to do on 4 of the 5 of them. In looking at the sensitization of, I think when you look at the literature, it basically says what you're going to do when you're optimizing is look at the question of either the voltage with ranges, or look at the electrode configuration, which is the stimulator lead. Its default setting is positive, positive, negative, positive, and you can go to negative, negative, negative. And when you're doing the interrogated dices, all that you're doing is looking at the stimulator lead. What we've been doing a lot of is looking at the sensory lead, and looking at at either the cycles themselves or their sensitivity thresholds in the advanced settings that you can look at during the sleep study. And if your sleep techs are not doing that, I would, and I'm happy to talk about this offline. We had a child who became an adult down from Alabama who we spent 2 years trying to optimize. I was completely convinced it was a failure, and now has an AHI of 4. And
Right.
it's just, yeah, and it's really where, and it's stuff that we're gonna, if you get interested in it, I'm happy to write it up with you. We're gonna write this up in the pediatric. I don't think it's, I think there's been so much attention to the stimulator lead and not enough to the sensing lead, and why that is actually triggering it. Where it also, I'm gonna wax eloquent on this because I'm so happy about this. It's allowed us to go down on our voltages on a handful of kids to the fact that they didn't feel it afterwards, where we were sort of cranking up the voltages, thinking maybe it just wasn't, we needed higher voltages. It's sort of, hitting something over the head with a hammer. Whereas once we adjusted the sensing component, it became much better. Does that make sense?
Yeah, thank you very much.
Yeah.
Very helpful.
Chris, what's the sensing lead? Is it in the diaphragm, or is the stomach wall, or?
It sits on top of the rib cage. Either it can be either on the second and above the second and third rib, just underneath the external intercostal, or anywhere near there, or I used to put it down around the fourth or the fifth rib, but it's there in the just above the ribs.
I wonder if those kids, because they do have low tone, they might have a little bit of paradoxical respiration due to low tone. Maybe that's why.
It could be.
So let's see. I actually have a couple of questions here in the chat. One from Jyoti Lenka. I think this dovetails with this. Talk a little bit more about the titration method and the sensitivity parameters. I think we kind of covered that.
Well, I would just say that we learned a lot by the other part of the sensitivity of the titration is in the first study. We didn't really know what we were doing for kids, and we didn't know for for the kids we didn't think the kids or the parents would be ready to deal with a range. So and we weren't sure, and getting functional and sensory thresholds on a child with Down syndrome in the clinic is almost impossible. So it's and so you're looking for what's called bullfrogging when it goes on, more than asking them to open their mouth and see or to tell you when they have pain. So when we were first doing the study, we were doing sleep studies at the 1 month, 2 month, 6 month, and 1 year mark post, which is 4 sleep studies, which was by the way a bear to get approved. But we were learning. What we learned, and we were not going above 1 volt. We were not the first one, and slowly we were optimizing it. Now we're for the study we're doing 1, 3, 6, and 10, and for the first, and what we're saying is for the first night we're ramping up as high as we can until either the child has an AHI under 5 or until you start seeing arousals, in which case you're stopping there and giving teaching the parents, who parents are always smarter than us as docs, and so they were perfectly fine with working with the range. So we've really changed it in that way. For the kids who are over and BMI over 95th who aren't part of the study, we're doing it pretty similar to I think how you guys do it as the adult scenario, where we're turning the device on in the clinic and with doing the best we can with sensory and functional thresholds at the 1 month mark, and then getting a sleep study somewhere between 3 to 6 months later after they've had some time to acclimatize to it.
Another question here from the sleep fellows. And I think this is probably, we may not know the answer to this yet. Follow with children who've been implanted. Do you anticipate or have you needed further surgeries if when they've grown?
Well, so far of the kids we've implanted now 6 kids who were implanted between the ages of 10 and 13, who then when they became fully grown, well, we just paid a lot of attention to the wire, the way that the leads were to allow them to have growth, and 6 is a small number. So I mean, this is beginning days. So I will say all 6 of these kids, once they became fully grown, did not need revision surgery in order to for the implant. I've had to re-implant now 2 kids now, not to re-implant them, but to change the battery. So the battery does need one child was at age was 9 years out, and one child was I think 10 years out. or maybe 8 years out, but somewhere between 8 and 9 years, 2 of the kids. But that, just like in the adult implants, these are pacemakers, and they're battery until they come up with a rechargeable pacemaker battery. Those batteries will get changed, but not surgery to change the wire configuration because of growth.
Chris, do you think, many years ago, you and I cared for a patient at Shriners who you probably remember had facial burns, needed a tracheostomy, had the tonsils out, was doing well on CPAP, was going back to China in a place where was not going to have consistent access to power. Do you think there might be an application for children in other parts of the world where CPAP is just not practical?
I spend a lot of time in now in El Salvador and Guatemala and Colombia and different areas of in the world. I worry a little bit about this. It's an implant. Yes, it does. I mean, yes, I can understand what you're saying in the sense that you still, this would work by just regular batteries in that situation, but it is hard to get regular batteries in certain places of the world too. So, and this is a pretty high-end technology if things go wrong, but I don't know in terms of with rural settings with poor access. But there is a lot of interest around the world in this device, and they are certainly implanting it now in the Far East in areas. When we were caring for that child in China, I do remember it wasn't possible. Now it is possible. I see a hand raised.
Yeah, Dr. Zinchuk.
Oh yeah, thanks. So excellent talk, and really interesting to see how this sort of plays out in the pediatric and actually the specialty pediatric population. And so I I run the program here at Yale for the upper airway stimulation, and what we found is that the performance of the device may not necessarily mirror what we see in the STAR trial, for example. And so just curious, from your experience with it for the last couple of years, are there certain characteristics of sleep apnea or the anatomy or the patients that you found to be helpful at sort of deciphering who might do better versus who might not do better, knowing that, of course, you're going to go sort of through the classic criteria that you use for inclusion and exclusion?
Yeah, it's such a good question, and the emphatic yes. I would say, it's a little bit like this concept of circumferential velopharyngeal collapse. It's as if it was a dichotomous variable. It either is circumferential or it isn't, right? Whether or not you use a Vogt classification or whether or not there's the Dylan Chandler for kids, which includes adenoid. It's so I have to say that as I've started to do this more, I have preceded the dice more and more in kids who they kind of would qualify. They don't have complete circumferential, but I just don't know. I wind up doing a more expansion sphincteroplasties on those kids first before I go ahead and put an implant in. Or certainly if it's not optimizing, I go back and look at that a lot, and I've done that as a revision. I've certainly seen things like lingual tonsils. We go back and forth and say, they're not a contraindication to an implant. But if the child isn't doing well, but their implant, we go back and we remove their lingual tonsils. For myself, it's different in the sites around the country. I tend, if I see any lingual tonsils, to do a lingual tonsillectomy before I'll do an implant. But there are definitely sites around the country, even within our group, that feel a little differently about that there'll always be some lingual tonsils. And then I guess I think the outstanding question of BMI and its relation, I'm not sure about yet. I don't know.
Gotcha. And so I guess the other question I'll ask you is, so it sounds like the titration or the post-implant period is a bit different for the children than it is for the adults, unless you're looking at the more extreme range of the BMI. And so in your trials, are you continuing to do these, 1 month, 3 months, 6 months PSGs, or are you following them a little bit more clinically and then doing 1 or 2 PSGs and follow up?
What was kind of the hard part about this was we got the NIH funding for the study before the end of the first 42. So there was an overlap period. So by the time I had learned of the 42, if I had a do-over, no, I would not do a 1, 3, 6, and 12 month study. I don't think we need that. Does that, you know, and certainly post, I would go much more to how the how probably you do it, and the adult experience. That was part that, you know, that is part of our study. And since it's to change 5 IRBs and 5, you know, and go through the FDA, I don't have it. I'm not going to go. We weren't going to redo that since we're now 20 patients in. But I don't think. I think the answer is you can turn these kids on in the, to my opinion, in the clinic. I don't think you need a 1 month study for that. For, you know, if I were doing it off label, I think you probably do need I'd be interested in what you're, for adults, how you do somewhere between 3 and 6 months. But I've been getting sleep studies on, you know, for those kids, just to be sure that I'm somewhere in the ballpark of where my functional thresholds were, just to be there. And then afterwards, I get a sleep study them according to what that first sleep study shows. You know, does that mirror what you guys are doing in the adult brain?
Yeah, I mean, I think it's pretty similar, and I can't tell you about all adults. I just tell you about, you know, what we do here at Yale, and I'm sure there are folks in Boston programs who might do things differently. But, you know, we oftentimes will, post activation, we'll see the patient a couple of times, assess symptoms, and what we do in our sleep lab is actually do some oximetry using a ring to make sure that, you know, at least we're in the ballpark of reducing the ODI before we bring them to the lab. Because as you're mentioning, you know, it's kind of hard to ramp up the voltage or even switch a, you know, polarity, because the tolerance is going to be pretty hard to, it's not like CPAP where you can go from 5 centimeters of water to 20 and the person could potentially sleep through it. Whereas here, if you go up in the voltage too quickly, so if they're not like 70 or 80% there before titration, we find that the patients wake up and have a hard time doing an advanced titration that way. Yeah.
Right. So, although I would say I would be interested in your experiences as well. To me, up until about a year ago, my advanced titrations were more focused on the stim lead and voltage and electrode configuration. Our advanced titrations now have really shifted to sensory lead first.
That's interesting. Yeah, I mean, I think for us, we still are primarily focused on the stim lead, not so much the sensing. There's maybe a few patients where we saw, okay, maybe making a change in sensing would be helpful, and we've always had the overnight Inspire rep available and doing that advanced titration on site. Because I think you're right. You know, even for our center, the technicians are not quite comfortable with recognizing inversion and dealing with that.
Well, guys, this has been great. I certainly learned a lot. And Chris, I'm going to have some of my ENT colleagues give you a call here, because maybe I think it would be really fruitful for us to have more of a collaboration on this.
Would love it. They're a great group and happy to. And thanks, guys, for. I always love this, because especially with the adult groups as well, I learned as much as I give from what you guys do. So thanks, and looking forward to collaborating more.
I appreciate that. Well, thanks very much, and we hit it off with a bang in our first conference for the year, for the joint conference. So we'll see you in 1 month.
Okay.
Bye, guys.
Thank you, everybody.